Hello and welcome to the topic Diabetes Mellitus. By the end of this lesson, you should be able to learn the criteria for the diagnosis of diabetes mellitus, outline the different types of diabetes mellitus, discuss the characteristic features of a patient with type 1 and type 2 diabetes mellitus, explain the pathophysiology of type 1 and type 2 diabetes mellitus, discuss the causes of secondary diabetes and other clinical syndromes associated with diabetes, describe the complications of type 1 and type 2 diabetes mellitus, outline the investigations required to diagnose this condition, explain the drugs and insulin types used to treat type 2 diabetes and their major side effects and difficulties with ensuring compliance, list the evidence-based guidelines available and explain how they can help with decisions. And lastly, discuss lifestyle modification measures recommended to treat diabetes. Let's get started. In order to diagnose diabetes, there are two circumstances to look at. Firstly, if the person is symptomatic. Symptomatic here refers to having hyperosmolar symptoms such as tiredness, lethargy, polyuria or polydipsia, polyphagia, weight loss, pruritus vulvae, which is infection of the vulva with candida infection, as well as balanitis. So these are conditions which reflect high glucose level in the plasma circulation. Another circumstance to look at would be asymptomatic cases, in which patients do not have symptoms yet, however, they have the risk factors that may put them at a risk of developing diabetes soon. These include overweight or obese patients, plus one or more of these risk factors, where they have first-degree relatives with history of diabetes, if they have history of cardiovascular disease, hypertensives with BP of more than 140/90 or those already on antihypertensives, those with impaired glucose tolerance or impaired fasting glucose, those with dyslipidemia where they have low HDL levels and high triglyceride levels, anyone with signs of insulin resistance such as acanthosis nigricans, anyone having gestational diabetes mellitus or has delivered a baby weighing more than 4 kilograms, those with polycystic ovarian syndrome, and other special population which are on antipsychotic drugs and antiretroviral drugs. So these are the two scenarios where screening and diagnosis needs to be made. Now, these are the ranges and values for diagnosis. A normal blood glucose reading for fasting conditions would be less than 5.6 millimoles per liter, and more than 2 hours later after meals, your readings should be less than 7.8. Anyone with readings more than 7 and above for fasting or 11.1 and above for 2-hour postprandial is deemed diabetic. So there are many different types of diabetes mellitus. We will be focusing on type 1 and type 2 diabetes mellitus. The difference between these two types of diabetes depend on the severity of the onset, the presence of ketosis or diabetic ketoacidosis, the occurrence of obesity among these diabetics, any signs of insulin resistance such as acanthosis nigricans, presence of metabolic syndrome, presence of autoimmunity, and the underlying pathophysiology. So if you see here for type 1 diabetes, the pathophysiology relates to any conditions or causes that may lead to B cell destruction, hence reducing the amount of insulin secreted by the pancreas or close to none at all. However, for type 2 diabetics, they are mainly insulin resistance and have relative insulinopenia. Let's look at the characteristics of those with insulin resistance. They would have high blood pressure, polyphagic, have evidence of acanthosis nigricans as shown in the image over the left, as well as they have centripetal obesity, which is one of the important criteria to diagnose metabolic syndrome. As explained earlier, there may be genetic abnormalities or which can be triggered by environmental factors such as stress or infection, which then triggers a cell-mediated immune response, which is a delayed type of hypersensitivity response, which eventually destructs the beta islet cells in the pancreas. This over time eventually leads to a state of no insulin or not enough made by the pancreas. Hence, what happens would be no peripheral glucose uptake in the cells, and this leads to a high glucose level in the plasma circulation. Next would be the pathophysiology of type 2 diabetes. Here we have environmental factors as well as genetic predisposition of the patient, which renders the person to be insulin resistant. And when this happens, there also will be reduced peripheral glucose uptake, which then leads to hyperglycemic states. Let's look at the causes of secondary diabetes, which is one of the common causes of diabetes as well. Usually they are endocrine related, and these include pheochromocytoma, acromegaly or somatostatinoma, Cushing's disease or exogenous steroids intake causing Cushing's syndrome, polycystic ovarian syndrome, anyone who has underwent pancreatectomy, damage to pancreas due to cystic fibrosis, amyloidosis, hemochromatosis or chronic pancreatitis, and of course primary hyperaldosteronism. Complications of diabetes can be largely categorized into two, which are acute as well as chronic complications. Acute complications are important to understand as these may render the patient to be at a state of emergency or life-threatening state. In states of hyperglycemia, consider diabetic ketoacidosis, hyperosmolar hyperglycemic states, as well as infections. And as for low glucose levels, an emergency that can happen would be hypoglycemia or neuroglycopenic coma in severe, persistent, uncorrected hypoglycemic states. As for chronic complications, they can be largely divided into macrovascular and microvascular complications. The macrovascular complications you want to look for include cardiovascular events such as acute coronary syndrome, cerebrovascular events such as strokes, ischemic or hemorrhagic, and peripheral vascular disease, causing peripheral arterial disease. Microvascular complications include retinopathy, which eventually leads to blindness, nephropathy, which eventually leads to end-stage renal failure, and neuropathy, where the patient might have distinct muscle weakness or sensory loss. Let's look at some principles of management of hyperglycemic emergencies. Here we want to look at the 4 important points, which include fluids, insulin, electrolytes, and monitoring. You can use the acronym FILM, which stands for film, to remember these principles. It is important to understand the approach of managing hyperglycemic states from these 3 points of view, which are why they need to be corrected, when they need to be corrected, and how they can be corrected. For the diagnosis of diabetic ketoacidosis, there has to be all 3 of the following criteria being met, which include capillary blood glucose of more than 11 millimoles per liter, capillary ketones of more than 3 millimoles per liter or urine ketones 2 plus or more, and venous pH of less than 7.3 and or bicarbonate levels less than 15 millimoles per liter. Having said all this, one also has to be in a state of compensated or decompensated shock and will usually appear very sick and lethargic. The image on your right depicts the first hour immediate management that needs to be instated in a person who is diagnosed with DKA. As you can see, the first step is commencing fluid replacement through boluses, followed by simultaneously commencing a fixed rate of intravenous insulin infusion, which is equivalent to 0.1 unit per kilogram per hour based on the estimated body weight, as well as continuously assessing the patient's vital parameters. Here, there has to be ongoing investigations done in order for you to outline or ascertain the possible cause of diabetic ketoacidosis, such as infections, thrombosis, or maybe a cardiac event. Lastly, not forgetting, think about the fluid and potassium replacement or the electrolyte replacements that's required. As the patient has lost a tremendous amount of fluid, which is equaling to about 6 to 8 liters, the patient might also have lost a tremendous amount of potassium or sodium, and as you are correcting with intravenous infusion of insulin, you will need to closely monitor the potassium levels as there can be an intracellular shift. These charts guide you throughout the hourly management for DKA until resolution. Ideally, diabetic ketoacidosis should resolve, if uncomplicated, within 24 hours. There should be no ketonemia and acidosis has to be resolved. If DKA is not resolved, identify and treat the reasons for failure to respond to therapy. This has to be done within the 24 hours time period. Again, this is another example of a chart that can be used in your hospital to manage DKA patients at the point of accident and emergency department, which is time 0 to 60 minutes. And finally, as they arrive at the ward within the first to 6 hours of diagnosis. The resolution of DKA begins when the patient is already able to eat and drink on their own with normal insulin, and the patient is usually feeling much better with resolution of ketonemia and acidosis on blood gas. At this point of time, you can consider to overlap the intravenous infusion of insulin with basal bolus regimen of insulin. Let's take a look at an example of a monitoring sheet that is used for monitoring the progress of a patient with diabetic ketoacidosis and hyperglycemic hyperosmolar states. Here at the top, we have the random blood sugar levels that are picked up as soon as the patient is diagnosed, the venous blood gas levels, presence of blood ketones, as well as the corrected sodium levels and the serum osmolality. This is crucial because a high glucose level may depict a pseudo-hyponatremic state. Similar to the management of diabetic ketoacidosis, the management of HHS is about the same. The diagnostic criteria involved include hypovolemia, marked hyperglycemia. Typically, the blood glucose levels would be more than 30, and sometimes it will be very difficult to be picked up on the ambulatory capillary glucose monitor. and serum osmolality of more than 320 milliosmoles per kilogram. There is no significant presence of hyperketonemia or acidosis. And in such situations, if acidosis is present, the causes of acidosis such as lactic acidosis and toxicology screen needs to be investigated. The presence of acute cognitive impairment may be associated with cerebral edema in severe cases, or to the presence of significant electrolyte disturbances due to the hyperosmolar state. Also consider severe dehydration, infection and sepsis, hypoglycemia during treatment, and renal failure. Usually, patients would have lost almost 10 to 12 liters of fluid in a state of HHS. This is the protocol for management of adult patients with hyperglycemic hyperosmolar states. Here it is divided into 3 sections. The intravenous fluid, which will depend on the fluid status of the patient, whether requiring boluses, most certainly as they would be in hypovolemic shocks most of the time, followed by fluid replacement and maintenance. The second section here highlights the insulin, and if you notice, the dose of the insulin that is instated here would be half of what's required in diabetic ketoacidosis. Here we would typically use 0.05 units per kilogram per hour of intravenous insulin infusion. And lastly, not forgetting the potassium replacement. If the serum potassium is less than 3.5, ensure to provide adequate potassium correction, as changes in potassium levels can affect the heart rhythms. Now let's take a look at examples of anti-diabetic agents. You may find this chart from the Clinical Practice Guidelines for Diabetes in the latest edition. The row above depicts all the types of anti-diabetic agents available, and here we are comparing the profile side to side to see what are the advantages and disadvantages of the anti-diabetic agents and when are they suitable in what situations. So if patients have got renal issues, you may want to consider medications that do not disturb their renal function or are renally excreted. And for those in special categories such as renal disease patients or elderly patients, you might want to select medications that do not pose a risk of hypoglycemia to them. A quick introduction on insulin. So insulin is typically generated endogenously, and in situations where there's inadequate amount of insulin or insulin not being sensitive enough to be taken up by the cells in the body, sometimes the patients may require exogenous insulin requirement. And here we need to understand, in order to choose the insulin types for the patient, we first have to understand the peak of the insulin action, the onset of the insulin action, and how long does it exert its effect in the body. This is an example of a graph that shows us the difference between analog insulin such as Lispro, Aspart, and Glulicin, which acts very rapidly, and the duration of action ends within 10 hours since onset, as opposed to the long-acting insulin. Here would be Detamir and Glargine, which is also types of insulin analogs and can be given once a day due to the long duration of action. The common insulin that you would come across in the wards would be the short or the regular type of insulin, which is known as Actropid. Is given typically 3 times a day, as the duration of action spans about 8 hours. And Insulatard, which is the intermediate type or NPH, where the duration of action is about 12 to 14 hours. It can be given once a day or twice a day. Again, this is for your reference. The types of insulin, how they are delivered, the onset, peak, and duration. Next, let's look at the targets for control of blood glucose. So this again is taken from the 4th and 5th edition of the CPG. Here we directly compare the targets for control, where in the previous edition has mentioned a more tighter control compared to the latest edition has looked at a little bit more leeway provided for fasting as well as postprandial control. The blood pressure measurement or targets are typically less than 135/75, with good lipid control where the targets here would be less than 2.6 for LDL cholesterol and less than 1.8 for those with heart diseases. Take note of the individualized A1C targets at the bottom, where you have less tighter targets for those with comorbidities, short life expectancy, and those who are prone to hypoglycemia. These are evidence-based guidelines compiled together to form clinical practice guidelines. You may find them on the Academy of Medicine website or by just Googling them on the internet. Again, this is another example of a practical guide you may use for inpatient glycemic care. Here we look at strictly controlling inpatient glucose control in patients who are from various population and groups such as pregnancy, those who are subjected for surgery, those in the intensive care unit, as well as those who are stable in the wards. Last but not least, it is important to take a look at the lifestyle modification measures that we want to advise and consider for our patients. First of all, monitoring blood glucose is at most important. They will need to have a diary that charts their self-monitoring of blood glucose in order for the physician or doctor managing them to collect enough relevant data and suggest the best therapy. Together with that, they will also need to be more active in their lifestyle, at least brisk walking or simple jogging, comply to their medications appropriately, and finally have a balanced diet. These can be assisted by referring them to the nutritionist or the dietitian to educate them as well as provide a brief guide on where they can begin. So we have come to the end of this session. We hope this session was insightful and thank you for your time.